Yes, sir.
Yeah. Good evening, dear my professional colleagues. Today we are going to talk about the use of premix insulins in Indian context. I am your old speaker, Dr.Sepuri Krishna Mohan. I am an endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Karnool. So let's get into the topic. So today, a flow of contents has been divided into multiple headings. Unique characteristics of Indian type 2 diabetes mellitus people and risk associated with uncontrolled postprandial glucose levels. The insulin in the Indian context, the guideline recommendations, the case-based discussion, and insulin initiation with the premix insulin, and the take-home message. So, how are Indian type 2 diabetes mellitus patients are different from the rest of the world? That is not comparing with the Asians actually. The comparing the India is being taken as the model which represents the complete Asia, because we call the subcontinent India as the Southeast Asia. We are comparing ourselves to the Caucasians, the Westerners. Yeah, please, all of you, mute yourself. If somebody is making noise, please. The lady is, yeah.
Sir, mute చేసేసాను.
I don't like cross talks. Mute everybody, Prashant.
Yes, sir. Mute అయిపోయింది.
Yeah, right. Thank you. And the major difference between the Indians and the Caucasians, the whites or the rest of the world, is the dietary survey results in an Indian type 2 diabetes population that is called STAR study. The basic the inference is that we consume lot of carbohydrates. That too not the complex carbohydrates. We consume the simple carbohydrates. And you can see the any part of the country you can take, the northern part of India, the southern part, and the eastern part, and the western part, and the central part of India. The carbohydrate content, even the region wise macronutrient intake of type 2 diabetes group, that shows the minimum being 61 and the maximum being 67. So 61, 63, 66, 64, and 67%. The total number of carbohydrates that we consume. And the conclusion is the data from the present cross-sectional study shows that the carbohydrate content in our daily diet constitutes up to 64.1% of the total energy from the diet in the type 2 diabetes group, which is higher than the recommended level. So there was a clear non-adherence, that is self-reported to dietary advice in the type 2 diabetes group. So the inference is that the Indians consume simple sugars, not the complex carbohydrates, simple carbs, that too around 64% in their daily diet. This is the typical feature of this particular, as far as diet is concerned. And the other peculiarity which is not shown in this slide is that we are prone to get diabetes or even the hypertension 10 to 15 years prior to the Caucasian population. See, the reason being we have got a lot of insulin resistance than the insulinopenia actually. So sometimes it may be combined also. I don't say that we don't have insulinopenia. In our scenario, insulinopenia is absolute insulinopenia is seen in type 1 diabetics. And to some extent, the pancreatic bankruptcy in type 2 diabetes and in the other types of diabetes, whether the gestational diabetes or the pre-gestational diabetes or the other specific types of diabetes, also we find either this particular insulinopenia. But most of the times Indians, they do suffer from insulin resistance rather than the insulinopenia. And these are the two major differences between this particular the differences when compared to the Caucasian population as far as the type 2 diabetes mellitus is concerned. And coming to this busy slide, the relative contribution of PPC to A1C, Indians versus Caucasians. Actually, see, A1C is determined by the both fasting as well as the postprandial glucose. So, in nutshell, if I want to tell you, see, most of the times, if the patient is under good control, the most of the A1C is contributed from the fasting glucose, and the rest by the around 60:40 ratio, or around 60, yeah, 60 is the fasting and the 40 is 2 hour post glucose, that is the fed stage and the fasting stage. Whereas as the HbA1c increases, the PPC contribution increases in Indian population versus the Caucasian population, where the Caucasian population, it is the reversal. What I said is 60:40, that is 40:60. So we know that the normal fasting glucose and an abnormal 2 hour post glucose, 2 hour PG, is associated with increased mortality. Like 7 major studies are there. It's all, what all I say is documented and evidence-based medicine. Nothing that beyond that I'll not talk about anything. Everything, every sentence has got some research backup, and it's all evidence-based medicine. 7 major studies, the largest being the Honolulu study, that confirmed, and all the remaining 6 studies also confirmed that all the time an elevated 2 hour post glucose, let it be post breakfast, let it be post lunch, or let it be post dinner, is always associated with increased risk of mortality. Honolulu is nothing but the capital city of the American 50th state, Hawaii. That is not in the United States of America. It is in the sea actually. It is even from America, it is very far away when compared to the Japan. From Japan, it is nearer actually. That is the 50th last included state in the United States of America. So always remember the relative contribution of the fasting plasma glucose or the fed stage in terms of HbA1c, and as the patient becomes uncontrolled, most of the times the uncontrolled the postprandial glucose reflects the A1c. And risk with uncontrolled postprandial glucose. The uncontrolled postprandial hyperglycemia may lead to a wide array of complications. So you can see this cartoon. In the center we find the postprandial hyperglycemia, and this leads to the increased risk of the macrovascular disease, the increased carotid intima medial thickness, the decreased myocardial blood flow or the volume, the impaired early diastolic dysfunction, the increased oxidative stress, and the increased inflammatory markers, and the increased risk of retinopathy, and the increased risk of pancreatic cancer. See, the hyperglycemia per se is related to the microvascular complications of the diabetes, like the triad, all the pathies. Earlier it was nephropathy, the retinopathy, and the neuropathy. And nowadays the American Diabetes Association from the last 8 years, 2016, has replaced the term nephropathy by diabetic kidney disease, DKD. So not only the increased risk of retinopathy, all the microvascular, 3 microvascular complications of the type 2 diabetes are inversely proportionate to the postprandial hyperglycemia as it goes on. And if you can meticulously control this particular the hyperglycemia, the incidence is very much reduced. Whereas it is not same with the macrovascular complications, because the macrovascular complications being the myocardial infarction or the acute coronary artery disease, or the strokes, or the peripheral arterial disease or the peripheral vascular disease, because they are multifactorial in origin. For example, the paralysis and the heart attacks, they don't only depend on the diabetes. There are much the other comorbidities like the diabetes, hypertension, the dyslipidemia, and the lipoproteinurinemia and ApoB, and the family history of diabetes, obesity, sedentary lifestyle. So a lot of the smoking and alcohol, several risk factors are there. So there is an impact of diabetes on this particular occurrence of macrovascular complications, but when compared to the microvascular complications, which are basically the glycemic related complications, so if the glycemia is well maintained, well controlled, you can control almost the incidence of 70 to 80% the incidence of this microvascular complications, the triopathy. And whereas this the heart attacks and the strokes and the peripheral vascular diseases, they are multifactorial in origin. So one factor cannot be the whole and sole cause, like diabetes alone cannot cause that. There are the multiple factors which I have mentioned. So this slide shows, forget about the figures please, they are not very important. You take the message actually, the inference is very important. In any category of fasting glucose, an increase in 2-hour PG resulted in a significant increase in the mortality. That's what I was talking about. And all the time remember the increased the postprandial hyperglycemia is an independent marker of the mortality per se, the cardiovascular mortality, which includes the heart attacks and the strokes. And now the CVD is called ASCVD, that is atherosclerotic cardiovascular disease. So this slide shows the more patients achieve HbA1c targets by adhering to postprandial glucose targets than the FPC targets. The percentage of the patients achieving HbA1c target around or less than 7%. And on the left hand side you can say in patients achieving fasting plasma glucose target, that is around or less than 100 milligram per deciliter, it is 64% it is yes, and the 36% it is no. And coming to the right hand side, the cartoon, the patients achieving postprandial glucose target around or less than 140 milligram of deciliter, it is 94% it is yes, and only 6% it is no. And the inference is the control of, these are the normal levels actually, less than 100 of fasting plasma glucose is normoglycemia, less than 140 milligram of deciliter of the 2-hour post glucose is considered to be normoglycemia. So the patients, they are the individuals with no diabetes. The control of fasting hyperglycemia is necessary but usually insufficient for achieving HbA1c goals, a goal of less than 7%. The control of postprandial hyperglycemia is essential for achieving the recommended the HbA1c goal. So insulin in our Indian context. Here we are going methodically, step by step, according to the flow chart actually. See, the question is, are we starting the insulin at right time? Absolutely not. My answer is no. Because of several factors, and the main factor being the therapeutic inertia. That is the inertia from the doctor side, the clinician side, or the the physician side or the diabetologist side or the endocrinologist side, who are all the people involved in treating the diabetes per se. See, they have got the therapeutic inertia. That is, therapeutic inertia is nothing but not taking the right decision at the right time and postponing it. Whatever be the reason, there may be the inertia from the patient side also, but you must be able to counsel and convince the patient towards insulin actually. I'm extremely sorry. I'm not feeling well with this cough, cold and fever, but still I'm committed to this, so I'll not postpone this. So kindly bear with my the cough, please. The intensive treatment with OADs over a certain period has shown control, but eventually glucose levels they continue to rise steadily. This happens because of the pancreatic bankruptcy. You should know the basic physiology, like okay, and the pathophysiology of type 2 diabetes mellitus. That's what I told. We get the insulin from the beta cells of the pancreas, and by the time the diagnosis is made, the type 2 diabetes mellitus diagnosis is made, 50% of the beta cells are dead. So remaining only 50% are functioning. This was postulated by my mentor, Ralph Anthony DiFranco, who is the professor of medicine and endocrinology in the United States actually. Long ago he has postulated this, and of late 2007 he has come out with a new postulation. So he is called almost the father of the modern diabetology actually. So he has set up so many examples. He has postulated several theories. Even the ominous octet of the type 2 diabetes is postulated by my mentor R.A. DiFranco, Ralph Anthony DiFranco. And afterwards in 2007 in San Francisco, the ADA scientific sessions, he told that by the time you diagnose the case of type 2 diabetes mellitus, almost more than 80% of the beta cells are dead. That is the latest postulation. So eventually the death of beta cells is 4% per annum. That is how it happens. So the intensive therapy with OADs over a certain period has shown control, because initial 4-5 years of the diabetes, type 2 diabetes, any OHA would control that glycemic levels. But after that, what happens? The pancreatic beta cell reserve goes below 25%, wherein the oral agents they fail to maintain the glycemia, because there is no enough matching grant of insulin from the pancreas, because the beta cell death rate, that's what I said, 4% per annum, that is almost 5 years or 6 years, it is around some death of 20 to 25%. So initially it is 50%, and no OAD would act. So that is the time you have to initiate insulin. Even before that you have to initiate insulin. The time when exactly you have to initiate the insulin is when the patient, according to the recommendations, when the patient is on 3 drugs and is not able to get back to the normalcy of the glycemic triad, whether the fasting plasma glucose and the 2-hour post glucose and the HbA1c, these 3 are called the glycemic triad. And if the patient fails to get back to the normalcy, that is 80 to 130 of the milligrams per deciliter of fasting plasma glucose, or less than 180 of either the casual plasma glucose, which is the term replaced for the random plasma glucose, or the 2-hour post glucose. And the goal set by the American Diabetes Association as far as this particular A1C is concerned is around or less than 7%. If the patient is not able to maintain this glycemic triad, it is the time you have to respond with the oral 3 agents. You are not supposed to start a 4th oral agent. This is the first criteria. The second criteria, according to the American Diabetes Association, or even the American College of Endocrinology, or the AAs, that is, this is EAS and AAs is AAC, that is American Association for the Clinical Endocrinologists. The guidelines say that whenever the A1C is around or more than 9%, it is high time you have to initiate insulin with or without the existing oral drugs. So I suggest you to continue the existing orals. The 3 orals must be continued, and on top of it you add insulin. So in India, insulin therapy is initiated only when the HbA1c levels have deteriorated to around 9%. See, this is what happens. See, don't wait until the recommendations, what they say, 9%. Irrespective of that, the patient is not able to get back to the normalcy, you please initiate insulin. Don't wait until the 11th hour, the last minute. See, it is already the time where the patient developed either the microvascular or the macrovascular complications of diabetes. The treatment of type 2 diabetes mellitus is not mere bringing the blood sugars down, not only the glycemic triad or the glycemic pentad. That is not our this thing. There is much beyond glycemic control. That is what I mean to say is you need to control the complications, long-term complications and the short-term complications of the diabetes also. Long-term being the microvascular and the macrovascular complications, and the short-term being the one which is the lower is the hypoglycemia. If it goes beyond a point, that is the hyperglycemia, which is often we see ketone bodies, that is diabetic ketoacidosis. So the therapeutic inertia for the initiation of insulin still exists, because most of the times in our scenario, the patient says no, and the doctor also will not say yes to insulin, because the clinician has got a fear that if I say insulin to the patient, he may miss out actually. And this patient, either he or she may go to some other doctor. Please come out of the inhibitions, because everybody who is treating type 2 diabetes mellitus or anything, starting from the primary care physician to the secondary care physician to the tertiary care physician, everybody must abide by the guidelines, the recommendations. So don't be scared to tell the patient that you need insulin, and with a scare that the patient might leave you and go. See, this is not the way you are supposed to treat a patient. So therapeutic inertia for the initiation of insulin therapy still exists, and this delay may result in an increased risk of diabetes related complications. Hence, a timely initiation of insulin becomes imperative for reducing the future risk of diabetes related complications. And these are all the types of insulins. You know, all the earlier when I started my clinical practice, when I was doing my residency in diabetology and endocrinology in the King's College, the King's College Hospital, London, the Harvard Medical School, we used to see this the porcine and the bovine followed by the porcine insulins, and of late the Novo Nordisk has come out with, and the Eli Lilly, they have come out with the genetically engineered rDNA human insulins actually. So these are the human insulins, and most of the youngsters and most of the even the seniors, they might not have seen the bovine and the porcine. Now, broadly, the insulins are divided into human insulins and the designer insulins, which are called the analog insulins. These are the different types of insulins. The basal insulins, that is NPH, that is intermediate acting, and the long acting. We cannot say long acting. Detumer doesn't fall under long acting because it has to be given. That is the Levemir from Novo Nordisk has to be given almost twice a day, and Glargine U100, Glargine U300. Type 2 diabetes, it can be given once a day, whereas we have seen in the insulin clamp studies during our residency, we have seen in our the practicals literally that the Glargine fails to meet the set period of 24 hours. So where there is no pancreatic mass at all, functioning beta cell mass like type 1 diabetes, it wanes off at the 18th hour. 6 hours the patient will not have the Glargine. So in type 1 diabetes, Glargine, if at all you are using Glargine U100, you have to use it twice, most of the times. And the Glargine U300, of late it has come, and Degludec U100, Degludec U200. Degludec is the long acting the basal insulin actually. It works for more than 30 hours. So that has got the longest duration of action, and followed by the regular insulins and the short acting human, the rapid acting analogs, the aspart, the glulysin, the Lispro. The first that has come is the Lispro actually, followed by the aspart, followed by glulysin. The Lispro is from this particular Eli Lilly, and the aspart is from this Novo Nordisk, and the glulysin is from the Sanofi. So now this trend has changed, that they have got the fast acting aspart and the fast acting Lispro, and the inhaled, it is always almost a failure actually. Twice it came into the market and it was discontinued. It was only in the United States of America. Now it has not entered into our Indian subcontinent actually. So others are the premixed insulins, that is 70/30 NPH and regular, 70/30, 60/40, 50/50. We don't have 60/40, we have 70/30 and 50/50, and we have got the Eli Lilly people have got 25/75 and the 50/50. So 70/30 aspart protamine and the aspart and the protaminated aspart and the aspart, and 75/20 the protaminated Lispro and Lispro, which is called the Humalog mix 25, or the 50/50 Lispro, that is protaminated Lispro and the Lispro. It is called the protamination enhances the duration of the insulin. That is meant by the protaminated Lispro or protaminated aspart. The human insulin formulations, again short acting, intermediate and long acting, and the premixed. The analog formulations are rapid acting, the long acting and the ultra long acting. And now the ultra long acting, earlier we used to have this ultra lenti. From Novo Nordisk we used to have the human insulins ultra lenti, but because of its long duration, the patients were getting into hypoglycemias, and later on it was banned and discontinued from the market. and the premixed actually. See, these are all the types what we discussed in the earlier slide. And now coming to the guideline recommendations. See, the recommendations from the global and the Indian guidelines for insulin initiation. On the left hand side we can see the American Diabetes Association and the American Association for the Clinical Endocrinologists and the International Diabetes Federation and the CDA, that is Canadian Diabetes Association. They recommend to start with the basal insulin alone. And the NICE guidelines, that is the UK, the National the National Institute for Health and Care Excellence, NICE guidelines from UK, that says use either basal insulin or premixed insulin. The RSSDI, that is the research study for the study of diabetes in India, our own organization, Indian, the only one Indian organization for the study of diabetes. And the the European Association Data Study Group and the Diabetes Australia Clinical Practice Guidelines, including the Malaysia, they recommend either to start with the basal insulin or the premix insulins or the insulin co-formulations. See, there are multiple types of initiation of insulin in a patient, where already the patient is on 3 oral agents. You can start the basal insulin, that is the first recommended choice of insulin, along with the existing insulins. You can never stop the existing insulins if at all you are going for a basal insulin, because basal insulin per se will control the fasting plasma glucose, and 90% of the post lunch, that is the post breakfast, the remaining the things will not be controlled with this basal insulin alone. And again, coming to the basal plus therapy, again the basal bolus therapy, and prior to that the biphasic, the premixed insulins, either the human insulins or the analog insulins. And these are the international guidelines, the ADA guidelines 2023, the IDF guidelines 2018, the AACE 2022, the Diabetes Canada 2018, the ADA bar AASD combined, the consensus report 2022, they all recommended to start insulin, basal insulin analogs, or the premixed insulins, biphasic premixed insulins. These are the different recommendations for the insulin initiation from different international organizations. We also have the guidelines actually, but the guidelines from RSSDI are very much limited. The NICE clinical practice guidelines updated from 2022. That's what I said. This basically belongs to the UK NICE guidelines. So, start insulin therapy for adults with type 2 diabetes from a choice of the following insulin types and regimes. Offer NPH, the insulin injected once or twice daily according to the need. So most of the times, if at all you are using NPH as a basal insulin, it is mandatory that you have to use it twice, because the duration of action is only 12 to 14 hours, maximum 15 hours. Beyond 15th hour, not even a minute, okay? So you have to use twice. So likewise, the so many recommendations, and which is more important is, which is in the red box actually, they consider the premix, biphasic premix preparations that include short-acting insulin analogs rather than the premixed biphasic preparations that include the short-acting human insulin preparations. If the person prefers injecting insulin immediately before a meal, or the hypoglycemias are a problem, or the blood glucose levels rise markedly after meals. See the basic difference between the human insulins are still the gold standard insulins. I don't compel you, I don't put pressure on you that you should go right only analog insulins or designer insulins, because the scenario in our country is totally different. The patient has to pay the consultation fees from his pocket, her pocket. The same towards the investigations, he or she has to pay from her pocket. At the same time, again the purchasing the drugs also lies on the burden of the patient itself. So most of the times, the 90% of the prescription till today in India are for the human insulins, but the analog insulins have got lot of advantages when compared to the human insulins. Like the human insulin, premixed, biphasic premixed human insulin, if at all you want to take it, even or the short acting insulin, you want to take that, but you need to wait for half an hour before taking any meal, like the morning breakfast or the night, even the short acting, the 3 times. Every meal you have to make a gap of 30 minutes after taking the insulin, because the insulin will be in the form of hexamer. It has to break down once it is injected, as long as it is in the bottle or in the pen, it is, or the pen fills, and it is in the form of this particular the hexamer, which is an inactive agent of insulin, that has to break down to dimer, 2 atoms, 6 atoms have to break down to 2 atoms, and diatom has to break down to monomeric insulin, which is the active principle of insulin, and this process takes around 30 minutes. So without the active insulin is broken down, you take the food, the blood sugar spike you find, and this cannot chase that, but this particular insulin cannot chase the increased the blood sugars, that is hyperglycemia. That is the reason you need to wait for half an hour. And the incidence of hypoglycemia is more with the human insulins when compared to the analog insulins. And the third thing is the weight gain is also more when compared to the analog insulins as far as the human insulins are concerned. And the blood sugar control will be like much better when compared to the human insulins as far as the analogs are concerned. So this is our RSSDI 2022 clinical recommendations. Initiate with once daily basal insulin, once daily premixed, or the co-formulation insulin. There is only one co-formulation insulin in the world, that is from Novo Nordisk. No other company has got insulin co-formulation. Or twice daily premixed insulin, either alone or in combination with the other OADs. The based upon the patient's age, the clinical features, and the glucose profile, the risk of hypoglycemia, and the patient's preference. Basal insulin may also be initiated in combination with the GLP-1 analogs. So again, the Royal Australian College of General Practitioners, the RACGP, the Australian Clinical Practice Guidelines 2020 on the left hand side. Again the European Association for the Diabetes Study Group, the Clinical Practice Guidelines 2018 on the right hand side. You can see that they select one of the 2 insulin schedules, the basal insulins, the Glargine U100 or Glargine U300 once daily, irrespective of the meals, and the co-formulated insulin, that is Degludec and Aspart, or the premixed biphasic insulin, that is Lispro and the protominated Lispro, are the aspart and the protominated aspart once daily before the largest carbohydrate containing meal of the day. See, the preferred method of right hand side, the European recommendations I am telling. The preferred method of insulin initiation is to begin by adding a long acting basal insulin once daily, premixed or co-formulations in or the twice daily premixed insulin alone or in combination with the GLP-1 receptor agonist. See, when you compare all these things, more or less, the essence is only one. This is nothing but the old wine in the new bottle. One differs from the other in some way or other, but the final essence is the content and the message. The take-home message is only one and all. That's it, okay. And factors indicating the premix as the choice of insulin, and choose premix insulin which depend on the glycemic factors, the psychosocial factors, and the phase of the life and the Indian realities actually. Coming to the Indian realities, which is very important, if within limited resources, the simple and easy way to explain insulin therapy is needed for initiation and intensification. And if the patient is on high carbohydrate diet, that's what happens in our Indian scenario. The premix insulin such as Lispro, Premix 25 or the Lispro Premix 50 provide control of both fasting plasma glucose and the postprandial glucose along with the convenience of initiation, titration and intensification. See, I want to clarify why this 25 or 30, why this 70 or 75 is that the regular insulin in that particular is 25 and the protominated one is the 75, like 30 and 70. See, we use we start with 25 or 30 only, because the usage of regular insulin may lead to incidences of hypoglycemia, or it may increase the weight to some extent actually. So 50, when we come to this 50-50, when we use this is that the patient is a staunch eater, is a foodie, he takes a lot of food. In that case, where he is not able to get back to the normalcy as far as the glycemic triad is concerned, then we switch over to from 25 or 30 to 50-50. This is the take-home message. So premix insulin such as Lispro, Premix 25 provide control of both fasting and post-lunch along with the convenience of initiation. See, these are the three steps in the initiating the insulin and the titration and the intensification. 3 phases of the insulin dosage. So the patient selection and the premixed insulin. So it's a very busy slide, time consuming, there are a lot of slides to be covered, almost 40 slides, more than that. The considerations at initiation, either whether to choose premix or the basal. So the left hand side that favors premix, and the right hand side the table that favors the basal insulin. So what is the postprandial increment? If it is more than 54 milligram per deciliter, see the millimoles and the we use milligrams per deciliter, whereas the Western scenario they use the millimoles actually. So you want to convert millimole to convert millimole to milligrams per deciliter. You multiply with 18, that's all. 18.1 is the accurate one. With 18 it's okay. So what is the postprandial increment? So, and second, is the patient likely to manage basal bolus therapy when intensification is needed? No, if it is the premix, and yes, it is the basal. Is there a large carbohydrate intake at 1 or 2 meals? Yes, that is premix, or no, the basal. Is the patient's lifestyle predictable? Eating pattern, the working hours, and yes for premix and no for basal. See, premix versus basal insulins meta-analysis reports the factors that affect the choice of intensified insulin regime, number of injections, which are certainly fewer with premix insulins. Premix insulins, at the most, you need to go for 3 insulins. That's what the 1, 2, 3 study says. Giving once, twice, thrice. That is called the 1, 2, 3 study actually. Usually we confine ourselves to 2 times a day, and if it is not controlled, you can go for this is done with the insulin aspart and the protominated aspart. That is study was funded by Novo Nordisk people, and self monitoring of blood glucose, that is SMBC, and the patient's ability to inject insulin, which will be convenient in case of premix insulins. The Indian therapy, the insulin therapy in type 2 diabetes, which regime for intensification? See, the circled one, that is the high mix insulin, that is Humalog mix 50 scores over the Humalog mix 25 or the basal insulin. I have told you when to use 25, when to use 50. Intensification is 50. Coming to the case studies. Role of premix insulin in patients in uncontrolled on OADs. You know all these case scenarios. You've been listening to so many speakers. See the first it will be uncontrolled. By adding insulin, it will be controlled, and you need to initiate, titrate, and intensification. See, nothing new in this case also. The clinical challenge and all, and the coming to the evidence. The Lispro Premix 25 given twice a day plus metformin versus insulin glargine HS, that is bedtime plus metformin. See, to tell you very honestly, this is not a very good comparison actually. You take Eli Lilly people or you take Novo Nordisk people, they start comparing this premix insulin, the biphasic premix analog insulins with this particular the first basal insulin, the analog insulin, first basal analog insulin of Sanofi, the glargine U100 actually. I'll tell you a very surprising fact that this particular glargine is the research molecule of Novo Nordisk. But at the particular time when they came out with this particular glargine U100, there was no concept of basal insulin at all. Nobody knew what basal insulin is. So they were scared to introduce that molecule, and Sanofi bought it for only 200 crores. INR 200 crores, and by now the glargine people have generated more than 2 lakh crores, from just 200 crores to 2 lakh crores. So all the time the biphasic premix analog insulin, either 25 or 50, scores much better than the insulin glargine. You all know that, okay? So the same, the comparison of the overall hypoglycemia and the nocturnal hypoglycemia, and both are same actually, nothing very specific. And this one, the overall hypoglycemia is statistically significant, but not statistically very significant. Whereas the nocturnal hypoglycemia, it is not statistically significant. The overall hypoglycemia rate was low in both the groups, and then nocturnal hypoglycemia was similar in both the groups. And this is back to the case, addition of that, and at 3 months, the good glycemic control A1C was 7.5. So they started with the Lyspro Premix 25 10 units before breakfast. Later on, that is the initiation and the titration and the intensification all the time. And finally, after 4 weeks, Lyspro Premix 25 is 22 units and 16 units before dinner. The patient was doing good. See the role of premix insulins in patients requiring insulin intensification. The same story continues. We see the evidence and the similar A1C reductions and similar proportion of patients achieving glycemic targets with the Lyspro Premix 50 compared to the BBT. That is, BBT is nothing but basal bolus therapy. So this slide gives us an inference that Lyspro Premix 25 or 50 is not inferior to the basal bolus therapy. That is the beautiful aspect of this particular Lyspro Premix 50. So similar overall on the nocturnal hypoglycemia with Lyspro Premix 50, you can see there is no much change at all. No patients in either group experience severe hypoglycemia. Similar glycemic control without increase in the severe hypoglycemia with less number of pricks. That is only 2 pricks in this particular Lyspro Premix 50, whereas 3 or 4 pricks in the BBT. That is basal bolus therapy. You give 3 bolus doses and the 3 bolus shots and the one the basal shot actually. The prandial shots are 3 and the basal shot is 1. Again another case where the patient was switched to Premix 50 and his A1C was maintained at 7.4% after 3 months. So now it is high time to come to this summary, that is take home message. The significant contribution from the postprandial glucose even at a higher HbA1c in Indian population as compared to Caucasians, and premix insulins are simple to start with single injection with effective HbA1c control targeting both the postprandial glucose and the fasting plasma glucose. Patients uncontrolled on 2 or more OADs with the disciplined lifestyle can be initiated on premix insulin and dose can be titrated on a weekly basis. The premix insulins provide convenience and simplicity at initiation, titration and intensification, and the premix insulin provides both the convenience and the efficacy to the patient and aids in achieving the patient's good glycemic target. These are the take home bullets actually, the take home message summary. And you have any doubts, please type your question or query in the chat box so that the session is over. I can take up the QA session.